I am honored to introduce our guest speaker for the Healthcare and Pharma session at the Human Advantage Conference. Now, Susan Kirkendall, who is the CEO of BVNH Consulting North America and one of the BVA Group champion regarding healthcare, and myself will be speaking with Dr. Mitesh Patel. Mitesh is Vice President for Clinical Transformation and National Lead for Behavioral Insight at Ascension Health. And Dr. Patel was the founding director of the Penn Medicine Nudge Unit from 2016, I think, to 2021. He is a leading expert on using nudges, gamification, and wearables to improve health. He has led more than 25 clinical trials, maybe we will speak of some of them, in partnership with health system, insurers, employers, and community organizations that tested ways to design nudges, incentive, and gamification to change clinician and patient behavior. His work has been published in leading medical journals and has been featured in numerous media outlets, including the New York Times, NBC Today, Wall Street Journal, Washington Post, Forbes, Bloomberg, Time, NPR, and CNN. Welcome, Mitesh. It is really a pleasure, and we are very excited to welcome you at the Human Advantage Conference.
Thank you. Great to be here.
Hi, Mitesh. We're really happy to have you. So to start with, could you tell us more about the Penn Medicine Nudge Unit? This was the world's first behavioral design team embedded within a health system, which you created and led up until last year. So what inspired you to start it?
Yeah, as over the last decade, healthcare has really transformed in the way we make decisions. It used to be that clinicians were making decisions on pen and paper or through conversations, and all of that has now become digital through the expansion and adoption of electronic health records. On the patient side, things have also transformed in that, patients in the last 10 years have now all started using smartphones, wearables, other devices, so we can actually get data in new ways from them. And they're starting to engage more in things like telemedicine and patient portals. And those two changes, clinicians now adopting electronic health records, patients using connected devices, mean kind of two major things. One is that our opportunity to understand what decisions or behaviors are happening has changed. We can see what doctors have prescribed at the individual level. We can zoom out to an entire health system or insurance program, and we can look for variability in ways that we couldn't do when that data was on paper. And we can do that in real time. But it also means that we can intervene in real time when those clinicians or patients are making decisions through these digital choice, architecture platforms. We can change the information that's presented when they're prescribing a medication or ordering a test or treatment, or we can change the default options and so on and so forth. And so that really sets itself up to being able to understand how do we then change behavior. And that was the real idea behind the Penn Medicine Nudge Unit, doing this more systematically, testing different ways. Oftentimes people are implementing things in the electronic health record or patient portals and kind of moving forward. And we wanted to take a more systematic approach to see if we could change behavior and then scale that across our organization and other organizations around the world.
Amazing. So you mentioned things like defaults and other types of interventions that you could potentially do. Could you tell us more about some of your favorite projects that you did at the Penn Medicine Nudge Unit?
Sure. I can start with the project that really kickstarted the idea or the interest around the nudge unit. Our health system had been struggling at Penn Medicine for years on generic prescribing. As many people know, generics are the exact same as brand name prescriptions, the same chemical formulation, but brand name prescriptions can be much more expensive. And they tried giving clinicians feedback on their performance. We held grand rounds about how we were the worst performing health system in the entire Philadelphia region compared to others. We were even getting penalties from our largest insurer to try to motivate us to prescribe more generics, but it really wasn't working. And so we did a test within internal medicine clinics in the practices where I actually trained, and looked at what if we change the default. And there are different ways you can change the default. It can be what's displayed up front to what's on the final page. And ultimately, after some testing, we realized that we could let the clinician go about their ways. And the clinicians had said they wanted to prescribe generics, but they just don't always remember to do that, or the infrastructure is not there to make it easy. We added a checkbox that said dispense as written. If that wasn't checked, the prescription, whether you ordered the brand or the generic, went to the pharmacy as generic. If it was checked, when the physician wanted to prescribe a brand name prescription, then it would go to the pharmacy as brand name. And that small change took about an hour to implement, but it didn't happen very quickly. It basically took over 1 to 2 years for it to actually happen. This was before we had a nudge unit so that we could do this systematically. But it dramatically changed behavior. Our generic prescribing rate went from 75% to 99%, essentially overnight, and has stayed that way for the past 5 years. In just the first 2 years, if you just look at the top 100 meds for what we prescribed, that saved about $32 million in unnecessary prescribing. And much of that benefit went to insurance companies and the patients themselves. So that was like the light bulb moment for the health system. Wow, 1 hour of work. Had we done this, more proactively and systematically, could change behavior. What else is kind of going on in the health system, and led to a kind of a call for proposals, a crowdsourcing campaign for us to start collecting more things and working on this more proactively.
I think that's a really great example because it shows how behavioral science can be such an amazing tool that gives you ROI that nothing else can. When you really understand how to change behavior really effectively, you can do a 1 hour project and get $32 million in results. So that's really, really cool. So from there, that was the project that kicked things off for you all at the Nudge Unit. Can you tell us a little bit more about some other case studies that might inspire our attendees? That seems like a hard one to top.
Yeah, we have a lot of examples. I would say, the first, when we did the crowdsourcing campaign, we expected to get maybe a couple of ideas. We ran it for three weeks, and we got more than 225 submissions for people who said, hey, I'm a nurse on the front line of care. I can see that it would be easier for us to be able to, get patients triaged by doing this, or a clinician who would say, hey, we need to change the default for this and so we took that process. We held like a tournament, and the top 10 ideas got to present to the CEO, the CMO, and the leadership of our health system. And we picked 3. Those 3 were on how do we improve referral for cardiac rehab, how do we decrease unnecessary opioid prescribing, and then specifically in our emergency medicine departments, and then how do we decrease unnecessary imaging for patients who have cancer and at the end of life. And so I'll quickly talk about those. I'll start with the opioid one, since that's, we're still the world is going through an opioid epidemic. Kit Delgado, a colleague of mine in the emergency departments, began to realize is as they transition to a new electronic health record, the default for the opioids was 30 tablets. And that kind of makes sense if you come into the ED and you need emergency department and you need your cholesterol medication or your diabetes medication. We'll give you 30 days, and then you go see your doctor within those 30 days. But if you come in for a knee sprain, or you twisted your ankle or something, maybe you don't need opioids at all. But if you do, you certainly don't need 30 tablets. And so they recommended adjusting it to the guidelines, which were about 3 to 5 days of opioids. We settled on 10 tablets. And so we implemented that, Kit Delgado's team, and over the course of implemented 3 different emergency departments kind of in sequential fashion, and it cut opioid prescribing in half just by changing the default. Now, again, as many people know, defaults don't force clinicians to prescribe things. So if somebody did come in and they needed more, they could get that. But we were also able to default. So if you search for an opioid, it showed you Tylenol and ibuprofen at the top of the list. And then it showed you the opioid option. So it reminded you, hey, you could prescribe another medication with the opioid, so you can prescribe a smaller dose. And that's helpful because people who are on the size of the first opioid prescription you get is directly linked to whether or not you're going to be taking opioids a year or 2 from now and addicted to them. And so if we can decrease unnecessary opioids, that can be very helpful for public health. Another example in cardiac rehab. Cardiac rehab is a structured exercise program for 12 weeks after you have a heart attack or stroke. It's been shown to reduce readmissions and mortality or death by 30%. Lots of great evidence for it, covered by insurance. Cardiologists will tell us it's like fluoride in the water. Every patient should get it. It's like a free gym membership with a cardiologist on site to give you feedback on your medications and your diet. But less than 15% of our patients were even being referred. That meant if 100 patients have a heart attack at our hospitals, 85 go home without ever being told, hey, you should get cardiac rehab, and it's covered by your insurance. And what we found out is it was really hard to do. It was on paper. The doctors had to fill out like 25 fields while they were rounding on patients. And so we essentially did a couple of things. We made it really easy for the doctors. We pre-templated the form. Now it's all digital, but it used to still be on paper. All they had to do was sign off. And we changed the kind of the script for the patient. It's not, should this patient go to cardiac rehab? It's, is there any reason this patient should not go to cardiac rehab? From opt-in to opt-out kind of discussion. We changed the way they rounded. And then we had a care manager come to the patient with a vetted list of sites that the patient could go to and help them get set up for their appointment. And what happened is we turned that on, and the referral rate went from 15% to 85%. And has been maintained that way ever since. We had a comparison hospital that we compared to that essentially remained flat. And so it was net over a 50 percentage point increase in the referral rate. And referring patients is great, but we want to know, do they actually show up? And the show up rate went from 33% to 55%, so nearly double. But so net, if you take all the patients before the intervention, 15% were referred and a third of them went. So 5% actually went to cardiac rehab. Afterwards, it was 55% of 85, which is 40. So we went from 5% cardiac rehab attendance to 40%, eightfold increase. And if you think about it, we just made it easier for the doctors to do what they had wanted to do. And this is an area that we've been doing more work in as I've transitioned to Ascension around how do we decrease sludge? This idea of like all the stuff that slows down. And so that's a good example of some of the work from Penn where we decrease sludge. Final example, from that first crowdsourcing campaigns around imaging at the end of life, patients who are getting radiation to kind of to make the cancer less painful. They don't need X-rays and CT scans every day because those are meant to prevent bad outcomes 20, 30 years from now. But these patients only have days to weeks to live. But 80% of them were getting daily imaging. We realized that there was no default set in the electronic health record, so we just changed the default to no imaging. And the unnecessary imaging rate went from 70% to 30%. The goal was to get about 20 or 30% of patients still need it because they have a complex cancer or they're morbidly obese or something else. And so we were able to really drop that. We saved about 5,000 imaging tests a year. And those were previously bills that were going to the patient's families after the patient passed away. We also were able to give that time back to the patients at the valuable last days of life so they could spend that time with their families. So it was net a win all around.
Amazing. We're hearing a lot about the idea of that intention-action gap, right? Of physicians want to do this or patients want to do this, but it can be hard in practice. And so looking outside of interventions that directly target the individual, looking more at the system to make life easy for them or remove sludge, as you said. So very insightful, very clever. I'm really curious to hear a little bit more about that contest you mentioned at the beginning, because it sounds like it was open to kind of any healthcare provider in the healthcare system, which is not necessarily who you would think to go to for behavioral science interventions.
Yeah, it was really a learning moment for us. We wanted to do a couple of things when we launched the nudge unit. One is to be able to tell people about it. So this is a good, marketing mechanism for us to say, hey, we're the Penn Medicine Nudge Unit. This is what we do. We're focusing our first efforts on how do we improve high-value care, decrease low-value care. It was open to anyone. You could be a student, a nurse, a tech, an emeritus faculty member. Anyone could really submit an idea. And you're right, these are not the folks that we would ask for, hey, what's the best nudge? But what we wanted to ask them for was, what's the best opportunity to nudge? And then our team would help them design the nudge. And so the people who are at the front lines of care, they see these alerts in the electronic health record. They see the frustrations, the sludge, if you will. And so they're able to service it much better than if we were to ask the chief medical officer of the health system. They definitely know from a big picture what's going on, but being able to ask the front lines of care gives us both kind of sides of the coin. It was such a success that we decided that we were going to do that every 6 months. And so we ended up operationalizing that, creating a platform that we could use that people could submit ideas. You could comment on other people's ideas. You could thumb up or thumbs down it. So almost let the crowd kind of vote on what the best ideas were. And we would run it basically every 6 months. And at steady state, we were getting 60 to 70 kind of requests for help. And as time went on, we were able to increase the amount that we would take. So we used to do 3, we were able to increase up to 5 and then 10. And over the course of 5 years, we worked on over 100 of those different requests.
Incredible. I think that speaks really well to why the best practice is co-creation, right? Nothing about me without me is the principle that we all try to strive for with these sorts of things. So that's really cool to hear how you guys put that together. Very interesting. So you started to mention Ascension, which is where you're working now. What would you say is the biggest difference between the Penn Medicine Nudge Unit and the work you're doing now at Ascension? And can you tell us more about what you're up to these days?
Yeah, so Ascension is the second largest health system in the United States, the largest nonprofit health system. We have more than 150 hospitals across 20 states and the District of Columbia, and then more than 3,000 practice sites for outpatient clinics. And so it's much bigger scope. Penn Medicine was 6 hospitals within 2 or 3 states, and so that the real focus here is around how do we take behavioral science and implement it into the everyday operations of the organization, and then launch programs at scale. The initial focus has been on a couple of things. How do we change behavior from a patient perspective? How do we give them take some of the examples of the work that we've done at Penn and apply them before you go to see your doctor, after you go to see your doctor, to say, hey, you're going to see your doctor. Here's some topics that might be important for you to discuss. Or you just saw your doctor, they ordered these tests. Here's a link to fill them out, and then kind of nudging them to schedule them, and so on and so forth. But the thing we really started with first when I got to Ascension was, how do we reduce sludge? And we came up with a couple of things that we found. So one was a lot of the stuff that we could increase was just adding a digital option. So we were trying to change a lot of our members of the health system from one prescription benefits plan to another, but it was really slow. It was all done by phone call. You had to call in to transfer your prescriptions. And over the course of 6 months, the conversion rate was about 10%. So our pharmacy team would call 1,000 patients, and 100 of them would convert. And we had a backlog of 60,000 that we had to convert in the next couple of months. And so what we did is we took the members of the health system, and we did a quick test. We took about 1,000 of them, and we created a digital form embedded within the email that had it turned out we had your information. We had your home address. We had your phone number. You just had to confirm that it was still up to date. And then we basically gave them an option to be able to either submit the form without ever leaving their email, or edit it within their email and then click. And within 1 week, the conversion rate jumped from 10% to 72%. So 7-fold increase. And if you think about it, like, we weren't having this team manually calling patients and trying to find them and get them to answer the phone. And then the data was now in a digital format. So it could be downloaded, uploaded to our pharmacy benefits system, and the accounts were automatically created. So there's a lot of great work there. Another kind of thing we wanted to do was around compliance for COVID vaccination. Our members of our health system had to submit documentation, their COVID vaccine cards. But the process required a large number of steps. You had to take a picture. You can only do it through your computer. So you had to take a picture with your phone. Then you had to email it to yourself. Then you had to download it from your email. Then you had to log into a website and then upload it. And so compliance was low, not because people weren't vaccinated, but because they just weren't submitting their cards. And so what we did is we created a way that people could just take a picture and upload it right from their phone. And then we allowed them to do that really quickly. And we found that doubled compliance rates in the first few weeks after we implemented it. And so really reducing the number of steps. So adding a digital option, reducing the number of steps were a couple of the key things that we found that were really helpful for getting rid of some of the sludge in the health system.
Sounds like your first year has been off to a very good start. That's amazing. So a couple follow-up questions there. How has your experience as the behavioral science nudge expert been different on such a larger scale? Ascension, you mentioned, is a huge hospital health system compared to the one location at Penn Medicine. So I imagine the approach that you must take in creating these interventions and identifying opportunities might be a bit different.
Yeah, I think because we have basically 20 different kind of states and a lot of different markets, I think something that was critical from the start was getting a champion or an infrastructure within each of those markets, but being able to plug into the existing infrastructure. So at the Penn Medicine Nudge Unit, we had our own team that was really doing a lot of this centrally. At an organization that's much larger, these organizations tend to be more matrixed in that you have your behavioral science team over here, you've got your data team, you've got your marketing team, you've got your clinical team, and you have to now interface with all of those to be able to move things forward. So I think coordinating these efforts can be a little bit more challenging because you have to coordinate across them. But once you figure out a structure to do that, you actually brings a lot of benefits because each of those groups has their own expertise, and you're able to leverage that and then build a behavioral science kind of ecosystem within that. I think the important thing was really getting some of the quick wins, as I mentioned, to kind of establish kind of like, hey, we can really move the needle here. But I found that the organization has been really, open, supportive, and really hungry for being able to embed behavioral science within the operations of the health system. The real challenge is how do we get these programs to scale across the system. We have 50 plus electronic health record instances. Penn Medicine, we had one electronic health record. So you implement it, it's everywhere. Here we have to figure out how do we create a process for this distributed electronic health record system. And so it's had its own kind of operational challenges, but that has been really interesting in terms of the insights that they reveal around how we can embed this within clinician workflow and really make it easier for docs on the ground.
Makes sense. So what would you say you're most excited about for the future of behavioral science in healthcare? And where do you see it having the most impact, especially in the private sector?
I think there's a lot of opportunities. I would say, in the past, 5 years, the duration while I was working at Penn Medicine, we were doing a lot of building the evidence, demonstrating that we can take some of the insights that have been used in finance and retail and apply them to healthcare. And we have many examples, and every month there's another example of a nudge in healthcare that's being published. I think the real thing that I'm excited about is there's still a lot of room for us to actually get this embedded as an everyday practice. So it's not something special when we're thinking about behavioral science, it's just how we work. And so I think there's where the opportunity is. How can we get this when you're thinking about how do we recruit patients to a clinical trial, whether you're the health system or a pharma company, thinking about, do we frame the invitation as opt-in versus opt-out? Leveraging some of the work we've done, showing we can triple enrollment rates through that. How do we improve patient experience through this? And then I think as we start to get some of this embedded, it really creates the opportunities for us to start to use what we call behavioral phenotyping. That's some of the work I was doing at the tail end of when I was at Penn, is how do we match the right intervention to the right patient or the right doctor? A lot of the interventions today are one size fits all. An insurance program will deploy a program for 5 million members, but all of those people have different attitudes, past experiences, preferences, engagement. And so thinking about how do we test and scale programs that can personalize these approaches and then target them to meet the needs of the patient or the doctor. I think that's where we can make a lot of progress in the future.
Oh, that's really great, Mitesh. I am impatient to read a book from you with all your advice, experience. I think it would be really wonderful for a lot of professional to know more about what you have done, and also based on your experience, what are your recommendations for the healthcare sector. So I'm sure that you are very busy, but if you have sometimes, I would love to see and to read a book from you. So thanks so much for sharing this insight. Again, I think Susan told you it's really amazing, and I think really your experience is very helpful for all those interested in the application of behavioral science. Maybe one last question before we start our roundtable. What is the one piece of advice you would give to healthcare professionals who would like to start applying behavioral science?
I think the common thing that I hear from people are, I have a great idea. I want to change something within my organization, but I don't know where to get started. We don't have a nudge unit currently. We don't have a big team. We don't have experts in behavioral science. And I often tell people that the best way to get started at your organization is to launch something at small scale, learn quickly, and then develop that quick win or the credibility within the organization to start expanding that capability. Many people kind of are waiting for experts to come, and I think we're looking to train and help expand the reach. So I really my advice to people is if you have a great idea, go ahead and do it, but test it. Test in one group versus another, learn from it, and that'll give you the data you need to be able to take that small kind of intervention and build upon that and snowball to a large organization within your group.
So thanks a lot for this final advice, Mitesh. It was great to have this opportunity to discuss with you. Thank you.